Okay. All right. Tēnā koe, tēnā koutou katoa. Welcome. This is our bioethics seminar for this week. I'm Josephine Johnson. I think everyone knows me. If you're joining on Zoom, we just ask that you keep yourself muted during the seminar, and you are free to put your questions in the chat, or you can unmute and ask the question. If you raise your hand, I'll see that and I'll go to the people on the Zoom platform, and I will also take questions from the room. So first, though, we will have a seminar from Dr. Helen Patterson, who is coming to us from the section of the Department of Women and Children's section of Obstetrics and Gynecology, where she's head of section and she's a senior lecturer and she's also a practicing clinician. And she's going to present today on reproductive healthcare in New Zealand. Is the inequity of access to emergency contraception ethical? So over to you, Helen.
Kia ora. Ko Sagamartha Tamonga, ko Waitati toa Aotearoa and ko Aotearoa ko Helen Patterson tōku. So I stem from an unusual background. I was brought up in Nepal, and that's my home. I know I don't look Nepali, and then I trained in England and I came here in 2000. I did a whole lot of family planning work in the UK, but I really came from being brought up in this environment where I was surrounded by people who were talking about family planning, like it was just at the dinner table and everything. So this has been a passion for the whole of my life, I suppose. I think the ethics of this is really an interesting problem that we've got, which isn't really being discussed. It's one of the problems with New Zealand healthcare. We just sort of fund things. We don't really have any transparency about the sort of impact of people of not funding things and not making those choices. And I don't think we really go out into the community and ask people what's actually okay and what do they want. So that's what we tried to do.
Oh no, sorry, just give me one second. No, try.
There we go. So I'm just going to start off because I'm presuming my audience doesn't necessarily know a lot about emergency contraception. So I'm going to start off with a little bit of education because I can't help myself. And then I'm just going to present this survey that we just did with some emergency contraception users in New Zealand. So first of all, we need to change the principle that we have at the moment. I am completely about bodily autonomy. I'm probably a raging feminist if you really looked into my background. But the reality of contraception is that actually nothing works 100%. Not everybody has access to it. And actually pregnancy is the default position. So if you go back 200 years, people were having 14 plus pregnancies. The number of periods that people with a uterus and ovaries had was somewhere between 40 and 100 in their life, which is just tiny in comparison to what is happening now. And we have normalized that cycling and not being pregnant is the normal state, but actually it's not. And so we really need to think about this and think about it using the WHO framework would be a rights-based approach to the fact that you should be able to choose one, about having sex, which unfortunately is not always the case, but two, about when you want to be pregnant. Lots and lots of people don't have access to contraception, don't like contraception, don't want to use contraception, but might be in a situation where they are at risk of a pregnancy that they don't want. And this is the WHO methods. We don't really use YUPSI, which is the combined oral contraceptive pills anymore, and that's because they make you throw up and they don't work very well. And we have added in the Mirena can be used as well within 5 days of unprotected sex. So we've got a problem in New Zealand. Yes, we do. 53% of pregnancies in the Growing Up in New Zealand study reported as being unplanned. We know that that's not an equitable group of people. So you're more likely to end up with an unplanned pregnancy if you're it basically got more deprivation. And this is sort of a nice pictorial summary. But you know, what happens with unintended pregnancies is some of them are continued and some of them result in an abortion. and significant numbers in New Zealand that are unintended. Unintended is our acceptable language that we use now. We don't usually use unplanned. It's unintended is the terminology. So the two things that we've got in New Zealand, one is a copper IUD, and these are that are licensed for this purpose, and the other is a pill, Prostanor, Lavenel. It's got loads of different names. It's got a whole new name at the moment, but it's basically levonorgestrel, which is a progestogen. Copper is by far, hands down, the best form of emergency contraception we've got, but it involves having something put in your body, which is not a comfortable experience, and for some people is completely unacceptable, and also for some people is completely achievable because they don't have the money, they don't have access to someone who's trained and can do it. Advantage of a pill, you can go to the pharmacy, you can just take your pill. You do have to pay dollars for it at the pharmacy in some places, not in others, because, you know, we still have a postcode lottery that is related to a DHB, despite the fact that we don't have DHBs in New Zealand anymore. However, there is increasing data coming out around its efficacy for people who weigh more than 70 kilos. So this is the Society of Family Planning, and they're the people who've come out most recently with a statement about emergency contraception. So they're the most up-to-date sort of globally with things. And they're like, use a copper IUD. You can't use a copper IUD, then use allopurinol acetate, which we don't have in New Zealand, and making the note down there that you can use a Mirena, but it's not as good. So that's our sort of most up-to-date evidence. Little pictures just to show you what they are. So it's a copper IUD, pregnancy rate 0.1%, so it works really well. Levonorgestrel, pregnancy rate 2 to 3%. This is, all these studies were done pretty much in people who are under 70 kilos, because of course, what do? We go out to Asia and we do our studies there, and most people there were weighing less than 70 kilos. You have to take it as soon as possible and no later than 72 hours afterwards, which means ideally you want it in your cupboard or wherever you get your condoms from that don't work. So it should be accessible. And then this is a picture of the Mirena with pregnancy rate estimated at 0.3% for emergency contraception. Allopurinol acetate, which is not available in New Zealand, it has got still not as good as the IUDs, but much better than the oral progesterone, so 1.5% pregnancy rate. And whilst it may be impacted on by weight, it's much less impacted on by weight than the progesterone is. Okay, so these are the weight data, and basically depending on which group you pick depends on what the outcomes are. But if you weigh more than 70 kilos, or actually if you look at BMI of 30, then 3 to 8 times higher. Now, if you're just thinking that's 3%, 8 times 3%, since each month you only have a chance of getting pregnant of about 20%, that's basically, it doesn't work. Okay, so then they went and had a look, because they did this study with 26 people. I love it when we do these tiny little studies. We took 26 people, we gave them 2 tablets, 26 people who had a BMI of over 30, and we said, oh look, we get the same dose level in serum if we give them 2 as if we give them someone under BMI under 25 of 1. Let's just double the dose. And based on that wonderful study, the whole world started giving everybody 2. However, we did a study that shows that if you give 2 to people who have a BMI over 30 versus 1, it doesn't impact their follicular release. So it doesn't work. So we've been pandering to ourselves for the last number of years, feeling like we've been doing something good by giving people 2. And you'll hear some of the stories from those people. But actually, we've not really been doing anything with it. We've just been making ourselves feel better. So now you've been educated in emergency contraception. I'm now going to talk about our survey. So we did this with Sexual Wellbeing Aotearoa. And that in itself was, for me, a really awesome thing to do. So there were family planning New Zealand. And the fact that we managed to get a collaboration with them and go out together and start doing some research together, it was really great. The other thing is that the group of people that we had doing this included a consumer representative and a Māori contraception researcher right from the beginning. So we didn't take our data and then try and interpret it. We actually said, got them involved right at the beginning. What questions should we be asking? And Jacqueline went out, and so she's our consumer rep at the New Zealand College of Sexual Reproductive Health. She went out and she tested the survey for us and piloted it in people who were likely to give us really constructive feedback. And I really changed how I've been doing things since I've been working with this team in terms of bringing consumer on board as part of the team, right? So not people you go out and consult with, but actually on the research group and part of it. And Jackie's been that for us in this. Melanie Pearson is a research assistant who works with me. Ragnar works at family planning and is a research with an interest in qualitative. Tanya Huria, some of you may know, she used to work in Mihi in Christchurch for University of Otago, but she's just moved over to them. Beth Messenger is a sexual reproductive health specialist who's the lead at Sexual Wellbeing Aotearoa. So that was our team. Just sort of summarising a little bit of what I've already talked about, but thinking about this in the context of New Zealand. So if we think about weight in New Zealand, and I did a little bit of calculation. So the average height is at 163 centimetres apparently, allegedly, for women. If you weigh 70 kilos and you have a BMI of 30, you need to be 153, I think it was, or less. So you can have a BMI over 30 and weigh under 70 kilos. The 50 years med students were the ones that pointed this out to me. But most people aren't under 153 centimetres. It's not a common group of people. But if you look at it, majority of people actually weigh more than 70 kilos in New Zealand, and particularly when we bring in Māori and Pacific. And if we look at it, it does seem to be weight and BMI related. So if you had a higher weight but a normal BMI, you still got a higher failure rate because you're getting a lower distribution, presumably, of drug. So you're not getting that peak serum level. So clearly, the oral emergency contraceptive we've got is not going to work for lots of people in New Zealand. And also, it's going to disproportionately not work for Māori and Pacific people. Māori and Pacific people are less likely to use modern contraception. And we have done zero research to date on why. So we haven't gone and asked people why they don't use modern contraception. We have a higher rate of Depo-Provera use for Māori, but we don't know why. And we suspect that it might be clinician related rather than actually anything from a culturally safe standpoint or anything like that. So, you got to start to question, are we actually doing a reasonable job? So what did we do? We did an anonymous survey. We did it through Sexual Wellbeing Aotearoa, and we used Qualtrics. We were aiming for 200 participants. We knew we were going to get a biased population. We were purposefully going for some people who are likely to use emergency contraception in terms of our distribution. We thought we did pretty well in terms of having some reasonably wide representation. We got range of ages, and we also got a range of genders. The way that it worked was it was segmented. So if you said you were male, it was like, thank you very much, and for participating in our survey, and goodbye. And then as we went down, we lost more and more people as we went down the survey. So a reasonable number of Māori, not as high as we want, much lower rate of Pacific. And that's not surprising, because we know that Pacific peoples are less likely to engage with contraception than other populations in New Zealand. And sexual wellbeing Aotearoa is not been particularly designed and consulted for the Pacific population either. So they probably seek their information from other places. We got a range across the whole of the country. 70% of them had used emergency contraception. Only 1.3% had used an IUD. Now, we didn't go into this talking about have you used oral, so we weren't trying to get a select group. So this tells you a little bit of the background of just how accessible and how used the IUD is, and how much more common it is to use oral. We were pretty impressed with what they knew. They did think that ulipristal acetate was available, but other than that, they generally did reasonably well. It was even more impressive when we started to ask them the clinical questions, which was related to timing and weight, and them knowing what the right thing to do was. And so actually, this was a group of people who were reasonably informed in terms of what to do. So I thought, well, this is good, because then we've got an optimal population to be giving us feedback. So we asked them about what they should do if their sex was recent, if it was further away, and you can see 71% said use the pill if it was in 3 hours, but only 11 if it was over 3 days away. So they got the message.
I didn't understand that.
Sorry. My phone doesn't normally talk to me at all. So then we asked about cost, and this is really one of those things that you start to think about this and think about it from an ethical standpoint. The people who are least likely to be able to continue with a pregnancy are probably more, and we know from that prior data, are more likely to the people that are more got so more deprivation in various ways. And yet only 19% said there was no cost. Most people could afford it, but 15% had to borrow money or found it difficult. Okay, so we've got an issue with access. So then we asked them about stigma. I mean, surveys are one of those things that come in and you read them and you look at the data. They never get you that emotional. I don't know. I mean, they're just what I hear normally from a survey is just a few useful numbers. I sat and I read all the quotes that came through from this, and I literally had tears pouring down my face. So this one here showing us the coercion aspect of things. I'm over 70 kilos. I was almost talked into emergency contraception through a copper IUD. Please put us under, please give us painkillers. This is someone who's clearly distressed about the concept of this, but being told this is what they have to have. I felt judged for requiring it. There's stigma about weight, weight and promiscuity, awkwardness generally about asking about it. 21% of users who felt stigmatized when seeking emergency contraception. You go right back to my first thing, where you think the default state for someone who's got a uterus and who's ovulating is pregnancy. These people are trying to not become pregnant, and they're being stigmatized. And stigmatized in ways that is really, really unacceptable. So we asked them where they got it, and mostly it was from pharmacies, when they got it, and mostly it was pretty early. And then, was there an extra cost for taking 2 pills instead of 1? Especially bearing in mind that we know that actually it doesn't work either way. And 20% of them saying yes. The 28% that said they don't know, the thing is you charge what you get charged. And so unless you know to ask, you don't know. Those charges can be quite disparate. So the pill itself is super cheap, right? What it costs at Pharmac, but it costs $80 in some places for the consultation. And then when they give them 2, some places charge them twice. So even though you get 1 consultation, you get 2 pills, you get charged $160. So there's a lot of issues with cost because of the way that we've done this. And then in some parts of the country it's fully funded, and in other parts of the country it's not, through pharmacies, it's not funded at all. So another issue. So we asked then, okay, you got it. It was a horrible process. You were stigmatized. They charged you large amounts of money. You had to take a loan out to get it. That's bad enough. What about if you didn't actually get it? So did you need it but not get it? And then also just about the acceptability of having one in your cupboard, because that's how we in sexual reproductive health doctors think it should be. We think everybody should just have one in their cupboard. The safety profile is incredibly high. Impact of it, if you're pregnant, it doesn't do anything. It might make you feel a little bit nauseated at most. It really doesn't matter. It's 1 tablet, so it's not like you're getting a whole box of them and you're just going to take 1. So it's sort of like everybody should have them. They should be in free vending machines, kind of type thing, is the view of sexual reproductive health. And clearly there's some acceptability for it, that they would like it. So why are you not able to get it? So we analyze, you know how you put surveys out there and nobody actually, like, you put this comments box in and nobody writes anything in them, right? They tick yes, no, and then it says maybe or something really. We had 46 comments on why were you not able to get it. Okay, so the majority of people who couldn't get it wrote and told us why they couldn't get it. So we decided we'd analyze this as if it was a qualitative output, because there was so much data there. And we split it up into these. So affordability, availability, accessibility, acceptability, and knowledge. And these are some of the quotes. This one particularly, so I couldn't afford to get my emergency contraception and I ended up having an abortion.
And SA is sexual assault.
That one, that's GA.
No,
It's the same one.
Oh yeah, after sexual assault. Yeah, sorry. Yeah. So clearly the cost is an issue, but also efficacy we've discussed before is an issue. So then we educated people on allopurinol acetate. Never, ever, ever got over 90% in a survey response, ever, ever, ever before. I've got it twice in this. So do you think it should be fun? And we gave them a whole big education package. So we did have smaller numbers on this. It was, I think it was 170 that answered it. But they did, you know, they had to read like 2 or 3 pages about UPA. 92% said yes, we should have it, and 92% it wanted it to be readily available. And why did we ask that? Because the equivalency that we do have in New Zealand that is an anti-progesterone is mifepristone, which is used for abortion. And when we've suggested that perhaps we could use mifepristone, which is fully funded and available through Pharmac, although not for this indication, so it would be a Section 25 indication, we have had incredible pushback. So at the moment we've got a little project within sexual assault medicine, because obviously if you've just been sexually assaulted, the idea of having an intrauterine device put in could well be really traumatic for you, even though you really, really don't want to get pregnant. Those people are potentially less likely to be at risk of unprotected sex going forwards, because it's often, not always, but often a single event. And so for this event, we could use mifepristone for them, and we're sort of trying to roll that out gently. But there's been incredible pushback because it's an abortion drug. So the fact that 92% of people thought that it should be readily available, it demonstrates the fact that if you've got something that is designed for emergency contraception and licensed for that purpose, you don't get that stigma. But if you translate something across, you bring the stigma with it, and therefore you might just actually make access even more unacceptable for it. So clearly, in my view, what we're doing at the moment in New Zealand is not ethical. It's particularly suboptimally providing emergency contraception options for Māori and Pacific people, because the only easy to access as in oral doesn't work for a large proportion of them. It's also much harder to get an IUD if you live rurally. So we have a problem there. If you're poor, then you can't afford to get your medication, quite clearly. And probably not even if you're poor, but if you've got relatively low readily available funds. And it's still horribly stigmatized, clearly. So I would argue that we are not providing ethical sexual and reproductive healthcare. We need to do better. And so anytime anyone's giving me the opportunity to come and talk about this, I am, because I think need to change the hearts and minds of people, make the people aware that this is a problem. Because as much as I'd like to think that our system actually doesn't work on the biases, we know it does. So if we can educate as many people at your level, then maybe when I try and get the change put forwards, it'll happen. Which is what we're in the middle of trying to do, is put a Pharmac submission in and get LO1 into the country. I wanted to leave time for questions, so I purposely kept it short.
Thank you. I will just make this a little bigger. So we had this last week as well, where there were people listed down here, but we couldn't see anything. That's an interesting puzzle. But so I can only see that Kate is there, even though I can see a bigger number of participants. So not sure about that. But please let us know, Kate, if you want to ask a question. But in the meantime, I'll go to Lindley because she already raised her hand. So just like signal me if you want to put that on the list.
Thank you very much, Helen, that was great. I've given that paracetamol and ibuprofen are both available in the supermarket. Why not put it in the supermarkets? Instead of going for pharmacy where, I mean, you might still get judged at the checkout, but you could go through self-scanning. If it's as safe as that, it's obviously clearly safer than ibuprofen or paracetamol.
Absolutely.
And maybe people could have a packet in their bottom drawer in their bathroom that they might, I don't know, it might expire quickly. But and if it's as cheap as you say, then that might be a better thing to go for. This is for Plan B stuff, not this one that's not funded yet.
Yeah.
Have you thought about that?
Well, we've certainly talked about its availability in places where you get condoms, and in that context of they should be in the same place. And having recently done a tour trying to find lubricant around Wanaka, I can tell you that because I figured, well, I need some lubricant. I was for ultrasound scanning. I need some lubricant.
Justify it.
No, it was for ultrasound scanning, but I was like, I need some lubricant. The reason why, where would I get lubricant? Would come with condoms. Where do you get condoms? I don't know. I don't use condoms. So then I searched Wanaka to try and find where do you buy condoms. It turns out the supermarket is the place that you both buy condoms and lubricant. So, you know, on that argument, yes, it would be logical. Just stick it there. So I wonder if it would have to be a MedSafe change, wouldn't it? To being, because instead of it being over the counter, it's whatever the other name for it is.
And all that might do is remove ibuprofen from the supermarkets. The other thing I wanted to just ask is, have you done a talk to the pharmacy school?
No,
because
I've talked to a couple of them because I've been trying to find someone to do some research for me, but it's a good idea.
The stigma idea, obviously there's something not getting across. And it may not be the pharmacist themselves. It might be somebody who they're speaking to prior to getting to the pharmacist.
Yeah, but it still would be. Yeah. I'll try that.
Can I have some? I'll put you on the list. Yep. I just put myself on the list. I think I'm puzzled by the risk. Like, I think there's similar questions I have. So why isn't it easier to get the existing pill? Sure, them even if it's false, is there some history where people thought it was risky physically to take it or something? Like, why is this not a more easily available medicine? And what's the situation with the other medication that you think Ella won? Like, why don't we have that? Do you have any sense of the reasons, even if they're not reasons you support, for why these things are not available more easily?
So I'll start with the UPA, with the LO1. So the answer is that we are a country of 5 million at the other end of the world. And so if something hasn't been in Australia for a while, it doesn't make it here because it's just not economic for them. So it is now in Australia, and so they looked at putting an application in to MedSafe. It costs about $100,000 to put an application into MedSafe. Because MedSafe has had UPA in as another application at a higher dose for a completely different indication, which has had adverse effects associated with it, which was on prescription, and so it's subsequently been pulled and it isn't used for that. So this is a number of years ago. They've had UPA on prescription, and therefore they will not accept an application for it to go over the counter. They want it to be an application for prescription first, and then they'll consider whether it goes over the counter, which means it would be $100,000 and then another $100,000. And in a situation where prescription, you can see the majority of this is not prescription medication because people are getting it from pharmacies, and we want more availability, not less availability. it just wouldn't be economic for them. You know, they'd have to charge so much per pill that they've just said it's not. So there is a package where you can get Pharmac to kind of request MedSafe, and you go in the other direction. And that's what we're in the process of trying to do. So that we actually sort of get a request from us where Pharmac said, if this was available, we would then be looking for a tender to purchase it. In which case, then the MedSafe will be more likely to accept it as an over-the-counter medicine. So that's the issue we've got with LO1 at the moment. But prior to recently, it wasn't even in Australia. And so, you know, trying to get it in, you'd have to do it as a Section 29, which means only doctors can prescribe it. Going back in terms of the levonorgestrel, and even back with YUPSI, which was the combined oral contraceptive pill, it's the stigma. So
But
people,
like, do they not have to give reasons? Like, here's why this is and not more readily.
Yeah,
like,
so
we're not classifying it down here. We're putting it at this in between thing that gets to go to a pharmacist.
yeah, so there was a lot of a fight just to even get it an OTC over the counter at the pharmacy. And within that there was a submission. This is not here, this is in a different country, but a submission arguing that it's an abortifactant and that it works by stopping implantation. They've now shown that it clearly shown, there's now lots of research that have, for both of them, that show that they work by deferring ovulation. And the reason why that work had to be done was to be able to get them available over the counter, because they would not be available otherwise if they had an impact on a pregnancy post-implantation. So there's a whole lot of work that's been being done basically to fight stigma.
But MedSafe doesn't have to give reasons why something is risky enough that you need to talk to the pharmacist first.
No, so it depends on the application. So, well, it depends on the application in, and then they have to, you know, if they've got this, as with LO1, this pre-existing status of something. And of course, progesterone only pills, which is the same thing, but just take 21 of them or something like that, a prescription only. One can argue that they don't need to be either. I mean, my opinion, not based on anything at all, is that this is misogyny. It's the patriarchy. We don't want people to control their contraception. We don't want people to be able to control whether they have children or not. And that's how I but that's not just New Zealand, that's globally, right? You know, why is it is safer to take contraception, almost all contraception, that it is to have a pregnancy. The default, if you're not using contraception, is a pregnancy, and yet almost all our contraception is on, bar condoms, is on prescription.
So I thought that was sort of justified by some risks about blood clots and all these things. I mean,
Well,
not to say that they're necessarily good enough, but I just thought there was at least some sort of risk story.
So there is a risk story with the combined oral contraceptive pill. There isn't with the progesterone only contraceptive pill. I mean, if you've got liver disease, you shouldn't take them if you're yellow, right? But nor should you take paracetamol, but you can buy that over the counter. You know, you've got far more. Paracetamol is way more risky than almost any of our contraceptives. And with the combined pill, the reality is, so even the highest risk of venous thromboembolism with the pill, you're looking at an 8 times increased risk with the Jeanette, which is the highest risk, versus a 60-fold higher risk with pregnancy. So, you know, flip that, and that's a 10-fold reduction, right? If you change your headspace from the norm is to be pregnant, then you're actually reducing risk by taking this.
Maybe we should put 6 on as it, you need to require a prescription for it.
Yeah.
There's a question.
Okay, sorry, and then I'll come to you. Kate has a question. Oh no, there's a chat question. Yes.
That's what she was like.
Mike?
Thanks, Helen. That was great. This is about sort of farm. So you're talking about making a case to Pharmac.
Yep.
And Pharmac's usually been regarded as a bit of a black box on some of their decision making, although there was some clarity, but then you look into various things and it started to look slightly odd sometimes, the sorts of things they would fund and wouldn't fund as well. Now it looks like they've got these four factors that they consider, so they've got need, health benefits, costs and savings, and suitability. And they talk about what they are. So I suppose just first to note, they don't seem to, none of those say it's ethical to do it, but I assume that you do those things and they judge that's the right thing for them at least to fund it. And some parts of your ethical argument cover some of the things there. But I suppose, my question is, to what extent are you sort of confident that you know how to make a case based on the information that Pharmac has? It seems like it's very useful when people do this sort of work and can then make cases to Pharmac. And I just wonder if you could sort of comment on your perceptions of Pharmac.
So I should put up in my conflicts of interest that I sit on the reproductive sexual health group of PTAC, which is the advisory group to Pharmac. I probably do have some inside knowledge that it doesn't exist for some others. I'm actually going to take the credit. There's actually a massive part of Marina getting funded. So I wrote the submission for Marina that got Marina funded for contraception. So I had a lot of help but in fact got paid by college to do it. But yeah, so I do get it. I do understand it. I also understand that the problem is with Pharmac that essentially what they do is they use QALYs, right? So they look at quality of life and they have a major problem when it comes to pregnancy because they don't consider pregnancy as a default. So we had a massive discussion with them about Marina for contraception, because they were sat there telling me, well, but if we didn't do this, it doesn't matter because nothing happens to people. And so I literally got a little scrappy bit of paper and I drew and I was like, okay, so this is your risk of, because QALYs are mostly around death, right? So this is your risk with pregnancy. And he's like, what's the lines? I said, oh, they're dying. He's like, what do you mean? It's like, so, if you have lots of babies, you die. You die from having babies? Yes. So fundamentally, they were missing that. I mean, and we went and got the data and supported it for them, but missing that fundamental thing in terms of their QALY calculation. And so therefore, no contraception was ever going to really get funded, because if you don't consider the risk of pregnancy in terms of morbidity and mortality, then obviously there's no benefit to funding contraception. But and it's changed now, but there was a big focus on equity. They have rewritten their guidance under our prior government. It was lovely under this one, not so much. But I think there is still that headspace in there. And the other thing is that they are now abortion used to be something that they didn't really put into the equation because it was all funded in hospitals, and hospital funding at that time for drugs they saw slightly differently, because they didn't have this one big budget that they've now got for drugs that includes all drugs. So now I think actually that's probably quite a lot easier, because they've fully funded mifepristone, which is not cheap. It's $60 a tablet. So even if you go with your cheapest form of abortion, it's still considerably more expensive than levonorgestrel is. The question is, can we get elapristal to come in at a price range that actually works, and so makes it cheaper? So I think that's what we need to put to them when we're trying to follow their processes and doing it. But I do have that yeah, a little bit of insight into it.
I have Jingbao, then Tara, and then Neil.
Thank you very much. Aotearoa as a society shared the matter with this. I have two questions which are related. Do you know the ethnicity of the person who could not get contraceptive then end up with an abortion? This more particular question have a bigger question behind. That's I was struck about this, actually the inequality issue and the injustice issue with more Pacific people. But as we all know, there is a larger injustice and inequality against more Pacific people. So my bigger question behind the more particular question would be, what your research would be, how can we should perceive this as a part of larger injustice, and how does that can help to think other aspects of injustice, other like very high suicide rates, and especially youth suicide rates, and much lower life expectancy among other health indicators, well-being indicators.
Yeah, so we wouldn't have looked at specifics. We particularly split it up so that we weren't looking at individuals. So I don't know the ethnicity of that particular person. We do know that if we look at our abortion data, it's Māori have a higher gestation at the time of abortion compared to Pākehā. And we know that Pacific have a lower rate overall. The reality of the injustices, and this applies across. So if we think about Māori and we think about unintended pregnancy leading to unintended ongoing pregnancy and birth and all the impacts that has, that our highest form of maternal mortality in New Zealand is suicide, and it's almost all Māori, and so it's horrific, and we are doing precisely nothing about it, and that's data reported within pregnancy and 40 days of birth. But Pauline Dawson, who I work with, is just doing a project looking out to a year post-birth, and I haven't seen any of the data, but she tells me that it's representative of international data in the area, which means it will be awful and it will be highly representative of Māori as well. So we have massive injustices in reproductive healthcare and in support of what people need, but we're not even going out and asking what people need. So we haven't even started at the beginning. So we're certainly not going to end up solving the problem because we don't even know what people want. So we really need some good kaupapa Māori research, and for Pacific groups it's even harder. So we did some research in abortion. We did a survey of people seeking abortion care and their experience of access, and then we invited them to come for interviews. They got split into 3 groups, so we had a Pacific research group doing the Pacific interviews, a kaupapa Māori doing the Māori interviews, and then Pākehā doing the Pākehā interviews for acceptability purposes. And we got less than 10 in each group, despite it being a multi-centered study across the whole of the motu. So one of the problems is, one of the reasons we don't know why is it's so stigmatized in these communities that it's really hard to go and ask, to even never mind to actually understand. So, but we need to do better for sure. But I hope that answers the question.
Just a note on that, the stigma. I was walking down Frederick Street, I think it was last week, and a young woman came up to me she would have been like, where's the sexual health? Do you know where the sexual health clinic is? I can't find it anywhere. On the one hand, it's sad that it's not visible.
Yeah.
But I thought that's so awesome. When I was your age, I would have never stopped someone and asked where the sexual health. I would have been far too embarrassed. So I don't know if that's indicative of some change, but
We've got to hope.
yeah, you hope so. So my question was, one argument in favour of not having these available at the supermarket is that you go to a health professional and it provides a point of contact where they might have discussions about contraception. So if you're not already on contraception, you haven't started. Does that happen? And are people, I don't know, I can imagine if I was in that situation and someone started to talk to me about contraception in general, I wouldn't really listen. There's too much going on. So
Yeah, so that is one of the arguments, and it's one of the things that's put out there. Whenever you see someone for emergency contraception, you must plan their ongoing contraception. And I'm like, well, why? This is like abortion as well. So you see, we've just recognised an enormous amount of I'm going to call it bullying, because it's more than there's been going on from providers to people seeking abortion with regards to contraception. It's more than contraceptive coercion, right? It's beyond that. Prior to law reform, where it was like, this is illegal, and so therefore you must have this. And this pride in the rate of long-acting reversible contraceptives that people had as providers. I have a 50% rate of long-acting. Oh well, mine's 66. And since law reform, it's been really interesting, and there's still definitely some going on. And I just read a draft research today talking about contraceptive coercion in abortion clinics. But it is getting better. But that's the problem there as well, and it's the problem with emergency contraception. Number one, just because you don't want this risk of pregnancy doesn't mean you don't want to be pregnant. The two don't have to align. You might not want this pregnancy or this risk of pregnancy, but also your headspace is full, and you actually aren't in a place where you can actually have fully informed consent in 15 minutes, because that's all you're going to get at a GP's, right? And seriously, in 15 minutes, can you really learn about your emergency contraception, learn about your STI risks, learn how to take it properly, and have a whole conversation that is not coerced about other contraception? I suspect not. So I think we've maybe in the past, or maybe if you were in a situation that was a little bit different, more drop-in clinic, more free time, there would be more opportunity for discussion and education, not necessarily decision making. I would argue the internet has taken this over, and we could just have a little QR code on your thing, and you do it, and it goes and it tells you how to do it, and then it says, are you interested in further ongoing contraception? These are all your things, and it could just link you to it, and you don't actually have to engage with a practitioner at all. And then you get to choose.
Also, after having a baby, a few days after being the same day being discharged from hospital, let's talk to you about contraception. No one is ever going down there again.
So there's been quite a bit of research looking at the right time in pregnancy to do contraceptive counselling, and as with everything in pregnancy, the right time is the second trimester, because it's the time when you actually have a brain that's functioning, you feel okay, and so what we should be doing is looking at your notes and going, oh, I can see when you were 25 weeks pregnant that you said that you would want blah after you've had it. Is that something that you still want? Not, can I talk to you about contraception? Because
Exactly.
No. But I think it's quite similar, right? Is that when we've got times when we've got overload, trying to add those extra things in, it just doesn't work. So we just need additional ways to manage it. for people.
Kate asked, what is the cost of a pregnancy to the public health system? I'm not sure if that's a genuine question. I mean, because you might know the answer, but it's also a provocative question about cost. And then I did want to make sure Neil got to ask his question before we went, but you can answer this question.
Well, the cost of a cesarean section in the public system is $20,000. That's not the cost of a pregnancy. The cost of a pregnancy is the cost of a whole lot more than that, and it depends on the outcome of pregnancy and the outcome of that person's life and the trajectory of their life. So I think that's an incredibly complex question to actually ask. An abortion costs varying from $450 to $2,800 for early, depending on where you go and how you do it.
Neil?
Well, thanks so much, Helen. I just have a question about the equity aim. So the main thing I got out of two things. First of all, is that there are inequities here. There are certain groups who are disadvantaged as achieve that, so in many other ways who are further disadvantaged, which is a typical picture of inequity. And that you would like this UPA, was it?
UPA, yep.
To be available, or to be available actually. And my question is, would the latter help with the former?
Well, I think it would help with the weight if we had it readily available, over the counter, free at places that were readily acceptable and accessible to people. And I say that because whilst we know from the data around COVID vaccination that pharmacy, like 90, I can't remember the number, but 92% of people live within half an hour of a pharmacy or something like that. It's one of the closest health facilities to the majority of people. It needs to be something that's available, accessible, and acceptable to people, because some people don't want to go to their local pharmacy, right? For something that's stigmatized. I think that would help, but it isn't gonna get rid of two things. One, the reality is emergency contraception is still stigmatized itself, and so some people wouldn't even consider it. So we need education. And two, those people probably don't even know about it because of their health literacy. Right. So they don't even know that the option exists necessarily. So, we need to, if we're going to break down some of those barriers, there's a lot of different things we're going to need to do.
Thank you so much, Helen. That's very good. Thanks, Kate. So next week, the seminar on the 23rd, same time, same place, will be Dr. Rawiri Jensen, who is coming in person, even though he's not Dunedin based. And his talk is called Matapono me te mana tua papa, mo te mana matatika. So you will hear more about that next Monday. But thanks very much. Thank you.